Welcome to this ESC TV conversation with a real authority in the field of interventional cardiology. My name is Davide Capodanno. I like this format because it gives me the possibility to really ask whatever I want and have only for me and for you, of course, watching this video, Gregg Stone, who doesn't need any introduction. Thank you for accepting our invitation, Gregg.
My pleasure, Davide.
And in the next minutes, we will have a conversation and we will try to put into perspectives many of the data that are around and are really shaping in a different way or a dynamic way our field in interventions for coronary artery disease. So Gregg, first of all, I would like your opinion on which patients are really those that we should refer to an invasive pathway. Of course, I'm not talking of the acute coronary syndromes, I'm talking of those with stable ischemic heart disease or chronic coronary syndrome, as we say here in Europe. Who are the patients candidates for an invasive pathway?
Well, thank you, Davide. A lot of our current thinking has been shaped by the ischemia trial in patients with chronic coronary syndromes. And as one of the co-principal investigators of ischemia, I've had a lot of time, a decade, to think about that topic. So first of all, you differentiate acute coronary syndromes. And obviously those patients benefit from an expeditious or rapid invasive strategy with angiography, followed in most cases by PCI, both with STEMI and non-ST segment elevation acute coronary syndromes. For chronic coronary syndromes, it's a little more complicated. Some of the patients, we have to decide whether to cath for the diagnosis of coronary disease, and others we have a very high suspicion that they do have coronary disease, and then it's a matter of therapy. So for the first indication, right now, as you know, there's a heated, I don't want to call it a controversy, but there are several alternative pathways. In patients with a low to an intermediate suspicion of coronary disease, you can work patients up still non-invasively with CT scan, becoming, I think, the now favored approach. And CT gives you a lot of advantages. Not only do you see the coronary arteries, but you can also do CT-FFR to get an evidence of ischemia if you do have coronary disease. And at experienced centers, you can do CT perfusion as well. But then when you've got patients with a higher suspicion of coronary disease, then you have to decide, do you want to treat them medically, or do you want to undergo an invasive pathway? And if you do want to treat them medically because they've got manageable angina, and you've got a very strong suspicion that they do have coronary disease, that was the question we asked in ischemia. So you would, one, want to do in most cases a CT scan to rule out left main coronary artery disease and to rule in atherosclerotic disease. And two, then if you find moderately severe atherosclerosis that does support an ischemic heart disease diagnosis and they have stable controllable angina on medical therapy, then we learn from ischemia that there's no mortality advantage from doing an immediate catheterization, and there's no overall reduction in myocardial infarction, although there was less later spontaneous MIs at the cost of increased procedural MIs. So you can try an early conservative approach if that's what the patients want. But for patients with progressive angina, or for patients who have side effects from the drugs, they clearly are going to have better symptom relief and quality of life with an invasive approach. So then the question is, who is going to have a prognostic benefit with chronic coronary syndromes? And we still think that strongly that patients with left main coronary disease that can be managed with PCI or CABG depending on their anatomy and comorbidities according to heart team discussion, patients with extensive multivessel disease, and patients with left ventricular dysfunction. And ischemia specifically excluded patients with left main disease, patients with intolerable angina pectoris, and most patients with heart failure and left ventricular dysfunction, because those patients should be managed invasively.
So you touched the point of pretest probability essentially,
Yeah.
So we have really to rely on the symptoms. If you have to put in a ranking, symptoms, ischemia, anatomy, which one first now after the ischemia trial?
Yeah. I think it's hard to differentiate one from the other because one, they're all related, and two, they all do have prognostic implications. We shouldn't, from the ischemia trial, among the patients enrolled in ischemia, anatomy was more important than ischemia. But we enrolled a very homogeneous group of patients, all of whom had site-assessed moderate or severe ischemia. So you can't really look at that. There's studies from tens of thousands of patients showing that in chronic coronary syndromes, the extent of ischemia does predict cardiac death and myocardial infarction. So I do think that they're both important, although I do also believe mostly that ischemia predicts symptoms. They predict tight lesions with hemodynamic flow restriction, with exercise or other provocation, and relieving those stenoses relieves ischemia and improves quality of life. Most cardiac death and myocardial infarction, on the other hand, is caused by thrombosis of vulnerable plaques. And now many of those lesions are ischemic. And in fact, the more likely the lesion is to be ischemic, the higher the plaque burden, the more likely it is to be a vulnerable plaque. So that's why ischemia also predicts death and myocardial infarction. It's not from 30 seconds of ischemia itself, it's because it's a marker of vulnerable plaque. But about half of vulnerable plaques are not flow limiting, and those are also prognostically very important, as we've seen from multiple studies.
So let's say, let's imagine that our hypothetical patient has undergone invasive coronary angiography, so we give for granted that we have information on coronary anatomy. Then the point is whether we should revascularize or not. So of course, as you said, all patients are candidates for medical therapy, some patients are candidates for CABG, and then let's discuss patients who are candidates for PCI after an important trial that we have seen here at the ESC and was published in the New England, Revived. So I would like to have your reaction to this trial, first of all, also in the context of other trials that were not so positive for PCI.
Right. So first of all, when we get to a more standard ischemia type population, that was not Revived. We're still predominantly treating patients with chronic coronary syndromes who don't have left main disease, who don't have left ventricular dysfunction. Predominantly, we're treating them for symptoms. Okay, and we have to realize that. Yes, we may also reduce late myocardial infarction, but it's predominantly to improve quality of life. Patients with extensive coronary disease, left main disease, and left ventricular dysfunction, we even saw that in ischemia with the Duke stage 6 patients benefited, and the patients with moderate heart failure that we did enroll in ischemia also benefited prognostically. But Revived, which was presented at this meeting, was a fascinating cohort of patients that was somewhat trying to replicate the Stitch results, where they were looking specifically at patients with an ejection fraction of less than or equal to 35%. And they randomized 700 such patients, and they did not find that PCI improved prognosis in those patients. But I've had some fascinating discussions with the principal investigator, Davide Pereira, and they enrolled patients with very quiescent coronary disease. So again, they excluded recent acute coronary syndromes, but when you look at their patients, it was really a unique subset. There's very little angina. 3/4 of the patients had essentially no angina, and while they haven't presented the results of their ischemia studies yet, little angina means little ischemia. And then if you looked at the heart failure, there was actually relatively little heart failure. 80% of the patients did not have NYHA 3 or 4. And the ejection fraction by echoes the mean was about 31.8%. So it was really stable quiescent coronary disease that got into the trial because they had an ejection fraction of less than 35%. Most of the really active patients would not have been randomized to potentially medical therapy, patients having a lot of angina, or patients who were surgical candidates that might have been revascularized with surgery because of the Stitch approach. So even Davide doesn't believe that this is going to change practice for the majority of patients with severe heart failure or with a lot of angina.
Okay, so of course many have always the temptations when a new trial of PCI comes and the results are neutral, as in this case, to say, okay, but they didn't do that, they didn't do that. You are just suggesting that we maybe should be better in identifying patients who are, of course, most likely to benefit. And then this brings me to the question, what can we do to identify lesions that have really to be treated with maybe imaging, with anatomy, intracoronary, with physiology, or whatever else? The identification of vulnerable plaque. What's your take on that?
Well, you know, not every therapy applies to all patients, and we have to be really smart. We have a lot of tools that are available. So if, for example, we want to identify hibernating myocardium, the patients with heart failure, hibernating myocardium who might really improve by revascularization, they've got to have severe stenoses, right? From Lance Gould's work, when you get, it takes a diameter stenosis of 90% or greater, which to an angiographer from site assessment looks like it's a subtotal occlusion, right? Before you start getting resting flow decreased at baseline, leading to myocardial hibernation. And that's why I think in revived BSIS-2, there wasn't much of an improvement in ejection fraction, or not a differential improvement, because they didn't have a lot of those lesions. Okay, so if we have a patient who's got active ischemia and a lot of angina, we're looking for ischemic lesions to improve their quality of life outcomes. And that's what we saw even in ischemia in the patients who had even mild angina. We know patients with more severe angina are going to benefit even more. And that's going to hold whether the ejection fraction is normal or reduced. If we're looking for patients with left ventricular dysfunction who might benefit from revascularization, one, we want patients with, who are having severe heart failure, who are not well controlled on, we've got a lot of good guideline-directed medical therapies right now that do improve prognosis, and who may have a lot of hibernating myocardium with severe coronary stenoses. Not just diffuse 60, 70% atherosclerotic disease, but truly severe disease such that left ventricular function might improve after revascularization.
Yeah, and on the topic of plaque vulnerability, of course, in this moment after Revived, talking about prophylactic PCI, preventive PCI is not the right momentum, I guess, because even as a treatment, we are challenged as a field. But do you see in the future, because we are talking about the future, the ability of any test to really identify those plaques who are more prone to rupture and having a myocardial infarction?
Well, I think we actually have, now you're asking about vulnerable plaque, and I think we actually have a lot of evidence about identifying vulnerable plaque. And we have now more than 10 studies, both with invasive imaging, with intravascular ultrasound, radiofrequency ultrasound, near-infrared spectroscopy, and optical coherence tomography. And then we have about 3 or 4 good studies with CT angiography, showing that we can identify patients and lesions at risk for future rapid lesion progression and thrombotic coronary events. So we can identify vulnerable plaques. What we don't yet have are the definitive therapy studies. We have 2 studies in the pharmacologic realm, the Huygens trial and the Pacman AMI trial, that shows that from OCT we can thicken vulnerable plaques and we can decrease the extent of lipid by high dose intensive PCSK9 inhibitor therapy. And from the EasyFit trial and the Yellow trial, we know that statins will do that too, to a lesser extent. We have one trial, the Prospect Absorb study that we led, which was a pilot trial of PCI in patients with vulnerable plaques, showing that we can safely cap the plaque, increase the fibrous cap thickness, increase luminal dimensions, and even though we weren't powered for clinical events, we had a strong trend towards a 60% reduction in lesion-related vulnerable plaques. So we really need now outcomes trials. It's going to be 3,000, 4,000, 5,000 patients of specifically treating non-flow limiting vulnerable plaques to see if we can improve prognosis in patients.
So there is a solid background and foundation of like that is something that we would like to see. Okay, maybe in the final minutes I would like to shift gears, but we are more or less in the area of left ventricular dysfunction. And of course I want to take advantage, because you are PI of investigations in this area, on your idea regarding the left ventricular access device, both for high-risk PCI and for cardiogenic shock, because this is another potential controversy, because I feel it's a kind of data-free zone, so we need more solid data in order to endorse this use both in high-risk PCI and cardiogenic shock. What do you think?
So it's a great question. So we actually are treating more and more patients that we call CHIP patients, complex and high-risk indicated patients, that have both clinical comorbidities and complex coronary disease, and then either left ventricular dysfunction or hypotension or right ventricular dysfunction. So it's that triad, and when they overlap, we call that the CHIP patient. And that's increasing the number of patients we treat. They're often surgical turn-down patients. They're not the patients that were treated in Revived, which were kind of the stable patients. You're doing okay, but you've got an EF of less than 35%, can we make you better? It looks like for the most part the answer was no. But when you've got patients that are having ongoing severe heart failure and or ongoing angina with really complex coronary disease and left ventricular dysfunction, we still have strong indications to revascularize. And surgery is a great approach if the patients are eligible, but if not, then they're often given to us in the interventional suite. So the question has been then, do we need mechanical circulatory support to not only get them through the procedure, but by providing stable hemodynamic support during the procedure, allow us to do better intervention, allow us to get more complete revascularization, to choose the lesions more wisely, use more physiologic lesion assessment, intravascular imaging, and do better stenting. So can we do a better procedure and a more complete procedure? And you know, we only have 2 randomized trials. They're small studies. There's the, the original BESIS trial, which was, intra-aortic balloon pump in 300 patients versus control, and showed no acute differences, which was their primary outcome, but did show reduced 5-year mortality. But that was a non-pre-specified endpoint, so it didn't get much traction. And then there was PROTECT 2 that was Impella 2.5 device versus intra-aortic balloon pump, which missed its primary endpoint at 30 days and 90 days, but by a per protocol analysis was also positive, and the curves were spreading over time. And so, interestingly, the most recent, and in fact any European Society of Cardiology guidelines have never addressed, should you use mechanical circulatory support to support such high-risk complex indicated PCI. And the US guidelines give it a class 2B recommendation, doesn't differentiate between device types. So there's just not enough information. So we're running the PROTECT 4 randomized trial, which is 1,250 patients. Again, reduced left ventricular ejection fraction, complex coronary anatomy, often, a left main disease, severe multivessel disease requiring atherectomy, chronic total occlusions, et cetera, indicated for PCI, who are then randomized to either standard of care, which would be the PCI with either nothing or with an intra-aortic balloon pump support, or with a more potent transaxial flow pump, the Impella CP device. And our primary endpoint is not only acute, but it's actually 3 years. So it's the 3-year rate of death, myocardial infarction, stroke, or any cardiovascular hospitalization. So our hypothesis is we're going to, by doing better and more complete revascularization, we'll improve left ventricular function to a greater degree. That's going to lead to fewer arrhythmias, less admissions for heart failure, as well as, better stenting, so less restenosis, less late revascularization as well.
So we have to stay tuned, of course, to see whether these results will be compelling, but it's good news that we have a trial ongoing in order to see whether this technology will be embraced more broadly. So time flies when I speak with you, and I would have so many other questions, but our time is over, and I would like to thank you very much for having shared your thoughts about the recent developments and the next developments in the field of coronary intervention. I would like also to thank all of you for watching this video. Thank you, Gregg.
My pleasure.